There you go. All right, y'all. Hey, hey, hey. We shout out to the world of Facebook. I know it's probably we can see the simulations from her. Okay, great. I want to tell my Facebook folks and Instagram social media, please bear with us. This is something new. We are trying to streamline from the Centering Joy in the Black Birthing Experience Conference. And we got some simulations going for you all today, but I also have a group of people here with me who I am going to be engaging with as we watch these simulations be out here on our screen inside of this page. So, bear with us. How y'all doing today? So all my people out there in the social media world, you will be able to see it as well. Um, but also, if y'all could do me a favor, it looks like we're probably going to get started soon. Make sure y'all drop a comment and let me know if y'all can hear us out there in the social media world clearly. Please let me know. And yeah, we're going to get started shortly.
Come over because when we do that one, this is like quote unquote pretend like a home birthday. Yeah. And then she is going to come over and talk to Dr. Collins and say pretend like we just trained her because she starts to him. Okay. Okay, so is all this the image group next? Yeah, so we got you can live like give birth. Okay. If we talk to her about the vision, this is all okay.
You know we got pregnant belly on there.
Oh, she should have it. You want the pregnant belly? Yeah. Wait, is this part? Do we need a baby? They gonna transition over there.
No, she don't.
So, okay, we don't, we're still in the birth right now.
Yeah, we're still, I think she's going through the contractions and
It's supposed to be.
Can't choke that. At the regular. All the positions. Oh, you're doing so good. You're doing so good. Keep breathing. When you feel that urge, just go for it, okay?
Okay.
Don't be afraid. Just go for it as much as you can.
Where's the mask?
Good. You feel that building up right now?
Mm-hmm.
Okay, go ahead. When you're ready, go for it. That little bitty. Who have a baby like that?
I did.
That's what I want to hear.
We got the back with it.
Okay.
We got it.
Oh, my hide the baby. I was gonna try to give you try because we're gonna have the baby. I'm just gonna hide the baby. Like something.
Okay.
We're gonna hide the
Ready
baby.
to look
Okay.
at and we have
Okay. Come on. You got this. You got this.
Is my baby okay over there?
Sure
Do you
did.
need me?
Good.
Do you need me, baby?
Right here. Good. Good job.
Every way I can help you, baby.
Which one?
Every way I can help you, honey.
Dad, are you gonna help catch the baby today? Or you wanna sit, whatever you want. If you want to, you can. If not, don't hold it. Okay. I have to hold it. Good, good. Just go into that. Go into that.
come on,
Good, good.
You got
Good.
it.
Keep
Don't back
breathing.
down. Don't back down.
Go ahead. Bear down as much as you
You got
can.
it. Don't back down. Don't back down.
A little lower this time. More.
Yeah, there you go. There you go. There you go.
That's good. Good. Okay, I see a little bit of head right now. Good, good, good. Okay, okay. Slow down your pushes. Slow down your pushes. Little pushes, little pushes, little pushes, little pushes. Little pushes, almost. Okay, Dad, hook under the shoulder. There you go. There you go. Nice and easy. Okay, okay. Baby's out. Okay, we're going underneath.
Baby coming under.
Grab your baby, Mom. Come on. Grab your baby. There you go. There you go. Good job. There we go. Good. There we go. Oh, you did it. You did it. Come on, baby. You did it. Good job. Okay. Okay. Let's lean back a little bit. I kind of need to see what's going on. I need to see what's going on here. Keep just focus on the baby. Yeah, I need something for the placenta. I need a little bucket or something like that.
Okay, I get it.
Okay. Okay.
Okay.
You're doing good. I'm sorry I'm rubbing on your belly, okay? I'm sorry. Okay, I'm seeing a little more blood than I like. Okay, so Dad, let's cut the cord. Okay, we'll cut the cord. I can work on. Thank you so much. Okay, I feel like it's coming, but there's a lot of blood, so we're gonna. There you go. Yep. Okay, there we go. Now baby can come. I'm working on this. Okay.
Praise God, got it.
Okay. Do I have to feel a little bit? Okay, wait. Okay. Where we go that my box with the meds. Okay, doing so good. So good. Thank you so much. Okay. You're bleeding a little more than I like, okay? So I have some meds. I'm gonna put a shot in your leg to try to help slow down the bleeding, okay? I just need you to make a phone call for me, okay?
Okay.
We're gonna call Dr. Collins.
All right.
Okay, so we're gonna put some Pitocin here in your leg, a little stick, okay? Okay. Okay, I'm gonna keep rubbing your belly, all right? Okay. Center looks good. We're gonna put that to the side. Okay, doing so good. I know that it, thank you so much. Yep. I'll take the phone. Okay, okay. Hey, Dr. Collins, it's Talia. Yep, I'm at home with a mom, first time mom, just had the baby. Bleeding's a little more than I like, so I think we need to transfer. Okay, I will, on the way in the car, I'm gonna call the charge nurse and I'll send her records. Okay, I've already given her Pitocin. We're gonna try to start our IV before we leave. And we'll meet you guys there, okay?
Yeah.
Okay, and coming in through the ER? Okay, all right, we'll see you guys there.
Fight from the blood. It's gonna be okay.
Okay.
It's gonna be okay. Okay, all right, mama. You did an amazing job. The baby's here, okay, but we probably need to transfer to the hospital, okay? Because we got a lot more bleeding than I like. And at the hospital, they're gonna have more equipment to support you, okay? Sorry to give you some medication. I'm getting the IV started at home. I need someone to help hold my IV bags, and then we need to move for, and who's gonna drive? Then you gonna drive? Okay, I need some towels for the car. So let's get her ready to go. It's gonna be okay, girl. Okay, we're gonna get. You wanna hear? Mama, we're gonna help really nice and slow, okay? Yeah, okay, you can ride with me. It's okay, really nice and slow. Ready, 1, 2, 3.
All is well.
Okay, let's make sure the baby's good and wrapped up so the baby stays warm, okay?
All is
right.
well.
All right. All right, Dad, I need you close by in case she gets weak, okay? I need you to be, hold on to her in case she gets weak. Headed to the car. Grandma, just ride in the car behind us, okay? So you stay right by. Grandma's gonna ride with me.
Yes, Tyra's gonna ride with you, and I'm gonna stay with Jamal, okay?
All right. Done. This is over there. So y'all still extra down.
All right, y'all. I'm gonna move away from you 'cause now you all on camera. Hey. So how did y'all feel about that? Good. Good?
I think we showed all the players doing what they should be doing to support mom. I really like the doula supporting dad because he's in the space and he seemed like he wasn't there, but when doula started to lay hands on him and get him a little bit more comfortable and switch him around in positions, it seemed like he just came into the space a little bit more to support.
All the teams working together. That's what's up. Oh, don't worry, we got another one going. Let's see.
Not quite.
Not quite ready. Okay, I just want to make sure because he don't like him. Okay. So they're preparing for the next one. But I love what you said. All teams, and that's what I think we fail to realize sometimes is that doulas are there as teams. They contribute to the space. They're not there to take anybody else's space. They're like, we're assisting in the space. And like you said, as a provider, you can't concentrate on the dad, right? You trying to catch the baby. And sometimes you can't even concentrate on the mama because you're trying to catch the baby. So the doula is there like, and two doulas, shout out, I had two doulas I think in the space, right? One could concentrate on the dad and the other can concentrate on the mama. So having the team, I think is so much value. Anybody else want to have a thought? Go ahead.
I would like to thank.
Any other, what was your thought? What you think?
Well, I was just gonna say, just birthing position, like being able to birth in whatever position you want. So having bodily autonomy and also not feeling rushed or pressured into, speeding up the birthing process.
Ooh, did y'all see that she was on all fours? Mm-hmm. Have you, when you see birthing, do you usually see people on all fours? No. Where do they have them? So now we know you don't have to lay on your back to birth a baby. You don't have to lay on your back.
I would say as a PT, it makes so much more sense.
It does, with gravity,
Yeah,
right?
physical therapy.
If you push something out, you would want to think that you would be.
Mhm.
Well, I've always said we're the only species that lays on our back to have a baby. Everybody else uses gravity.
Yes.
That hospital settings, I definitely had my baby like that. In a hospital setting, it's important to talk to your providers, let them know what you want, and then just make sure you're doing the work to facilitate control what you want. What I didn't see was we kept going all the way down the hallway, so we couldn't get all the, we couldn't stop acting. And you got that far they were following. Hey, that's real. I was being fake. Okay.
The baby.
No, not yet.
All right.
They call me when it's time. If the baby's not there, I don't be there yet.
He said, call me when they're here.
Okay, so we're gonna talk a little bit about what happened in that last scenario. Answers. Before we do that, for the next sim, who signed up for the hemorrhage sim? Anybody signed up on the app? Anybody using the app? Okay. Who wants to go into the room? Hands high. Hands up. You do? That's 5. I can take 8. Okay, y'all stand up. Easy call.
I'll let somebody who.
One more person. One more person.
Carmen. No, somebody took my spot because I.
Everything I needed to express what's gonna be happening at a home birth for a transfer. But a lot of people are surprised to know that the home birth midwives have a lot of things in their bag and are prepared for transfer. So I have almost all the meds that they have at the hospital. We carry Pitocin, we carry Cytotec, we carry Metrogen. We carry TXA. And a lot of times we're already working on the interventions for bleeding before we make it there. So we had the baby. There was more bleeding than you would have wanted to expect. So it's important to kind of gauge what that is to know when it's time to transfer. Also, some of the things in the background that were happening were me already knowing what the labor looked like and anticipating the hemorrhage, and knowing who I was going to call and having a plan so that I wasn't scrambling to figure out who the provider was going to be. So for home birth midwives, it's really important that they already know. They know who's on call that weekend. They know who their friends are in the hospital. They have personal cell phone numbers, and they know who's going to answer the phone. So I had Dr. Collins already in mind. Usually I communicate with people what their schedules are going to be, so I know who's there when I have somebody in labor at home. We also start IVs at home, so I didn't have everything set up. But there's always at least 2 people at a home birth. A home birth midwife is never alone. There's always a birth assistant, or sometimes, most commonly, there's a home birth midwife, a student midwife, and a birth assistant, just to help have extra set of hands. And it's important for in case the baby needs resuscitation, there's always 2 people. Home birth midwives know if you don't have 2 people, when I did home birth, you transfer to the hospital because it's not safe to be alone. So the interventions that I did was a lot of fundal massage. We started Pitocin in intramuscularly. We started an IV to get fluids going, and then immediately I was calling to let them know that we were on the way. You never want to show up and automatically just assume people are going to be ready. We're going to give as much advance notice as possible. Another thing that a lot of people aren't aware of is that the home birth midwife is going to fax records from her phone in the car on the way, so that the charge nurse knows what's happening. They already know what blood type. The blood bank is getting ready in case they need blood. And so it's a lot more structured and systematic than a lot of people might imagine for a home birth. So what questions do you guys have about transfer or communication or anything that I didn't cover?
What would the kind of duration of that, from when you identify that it's more blood than you want, or there's a situation that needs to be transferred, to when they might arrive at the hospital?
When it's time.
Yeah.
Great question. It kind of depends on the scenario and where people live. Because home birth, that's a big variable with home birth. You might be doing a home birth on a farm that's 75 minutes from a hospital. Or you might have somebody who lives in the city and is 5 minutes from here. So that is a big factor in the decision-making of the home birth team, is what we're gonna do, how far away we are, where is gonna be the fastest place. So that happens in the prenatal care. In the prenatal care, when I show up for a home birth, home visit around 36 weeks, I have people print off an emergency plan that's on the fridge. So anybody can grab it and say, this is the closest hospital that has an OB unit. This is the charge nurse's phone number. And this is the hospital that we prefer to go to. If it's not an emergency, maybe we'll go here instead. So we have a plan for all those scenarios. So it kind of depends on the situation. But we try to be prepared for like A, B, and C kind of situations.
And the thing I wanted to say that I think a lot of people miss is that midwives, especially certified nurse midwives, are medical professionals. They can handle a situation as a medical professional. They are not rogue, free birthers. They are medical professionals, so they have the medical knowledge to manage a situation, but then to also kind of know when it's above their care, in the same way that a nurse practitioner would, in the same way that a nurse on the floor would. They know how to manage a situation and know when it's time for a higher level of care. And then the other thing I was going to say, because the last home birth I did was with you, the pre-plan is, I think, like the most important part of home birth that you can do, is to know where you're going, with who, if any additional phone calls need to be made outside of the charge nurse in the hospital. And you really have to be confident in that plan. As a doula, not all doulas do home birth. Not all people are comfortable with that, because there is that, I want to say, like, societal programming of it being less safe, like the stigma of it being less safe. But people have babies at home by accident all the time. All the time. And at least with a planned home birth, you are prepared for those one-off or those crazy scenarios.
Good point. Another thing I wanted to add is, when you're in a home birth, right now I'm in a hospital setting, but depending on the venue that I'm in is going to help me make decisions about when it's time to transfer. Like right now I'm in Mercy Birth Center, so I can allow a little more bleeding because I know it's just an elevator ride upstairs if I get in trouble. When I was at home, that's different. I'm going to make that judgment call sooner because I'm thinking about the car ride. I'm thinking about the communication with the team at the hospital. So my tolerance for bleeding is going to look different based on the situation. So,
in your situation that you described, is 75 miles away, are you on staff at the closest hospital? How do you ensure that, I think you said Dr. Collins.
Yeah.
Yeah. How do you ensure that Dr. Collins is aligned with your clinical practices?
That's a great question. Most home birth midwives, well, in the St. Louis area, there's not any CNMs that I'm aware of that do home birth that have hospital privileges. Okay. I know of one that is working on that, okay, but there's a lot of hoops, obviously, for that. One of the biggest hoops is the price of carrying malpractice insurance. Mm-hmm. So because the cost is so high, most of the time the home birth midwives aren't able to have privileges, and just because of the stigma, it's really difficult. So what you do is you go to community events, you go to the doctor's offices, you find who your people are going to be to help you, and you build that team. Mm-hmm. So you have an in-home team, you have your office team, and you know who your teammates are in the different local hospitals. Mm-hmm. So that work is being done previous to, even taking clients on. Like I've had people ask me to drive an hour and a half. And sometimes if I don't feel comfortable and safe about where we would transfer to, because I don't know the area, I'm going to find another midwife friend who's closer to give me some resources. So it's a lot of pre-work trying to figure out who has privileges, who are going to be your friend. And sometimes, a lot of times midwives, we depend on other midwife friends. So as a nurse midwife, I know all the nurse midwives in all the different hospital settings. And a lot of times they're able to help facilitate the transfer because they have the relationships with their collaborating physicians. So for midwife to midwife, a lot of times they can help me out, and then they can call their physician backups if needed. Some midwives in the community have relationships with physicians directly and are able to facilitate that. So it's really just about the pre-work you're doing, making connections to make sure you have a plan. In other cities though, in other big cities, I do know nurse midwives that have hospital privileges. So whether they're working in a freestanding birth center and then they can do a direct transfer. They don't have to transfer to another provider, but a lot of times they will have hospital privileges at specific places and then that's their preferred place to transfer to.
You ready?
Me? Okay.
I mean, so that actually,
Hey.
hey Dora, so that actually goes to Dora's question. So part 2 is showing how we can promote that team building with the community midwives and hospital team and how it can go smooth. So be back, stay tuned. Get questions.
In the meantime, does anyone have any questions about doula's involvement in the home birth?
So in that situation, I was just wondering in terms of the communication with the mom and the family about what's happening and how do you support
Right, I'm not
them through
sure
that?
how well you could see
Yeah.
what was happening. But as the midwife was telling her about, as the midwife was working on the bleeding and she's talking out loud, her talking out loud allows for the doulas, for the assistant, for the student midwife, whoever to know what's going on. So without her having to directly talk to us, then you can tell mom like, hey, you have a little additional bleeding. How are you feeling? We're kind of prepping. So once the decision was made for the transfer, the grandmother, she started crying. And sometimes family members can get hysterical. So I pulled her away because if you see your mom or your grandmother or someone like getting hysterical, you can't see what's happening. So that's going to make you hysterical, like it's worse than what you think it is. And so there are many times where I've had to pull family members away in home birth situations, in hospital situations. Sometimes we not even having a baby right now, but I've had to pull family members away and you kind of end up like doulaing the family. Like I say all the time, I doula every day I've ever interacted with because at some point in time you have to like rub their back and talk to them and keep them calm so that mom can stay calm. And then the other doula in the scenario, I just my dad started. And then the other doula in the scenario was talking to dad at the same time that I was talking to mom. So it's not often that somebody has more than one doula. I do. But it's wonderful when you're able to work with another doula and kind of spread the work out.
Y'all ready?
Thanks for answering the phone in the middle of the night.
Absolutely.
This is Miss Aikita. This was her first baby. Yep.
Okay.
She's a positive blood type,
Okay.
Rh positive. I gave her 2 shots of Pitocin. She's had 20 mils already,
Okay.
CID hanging.
Okay.
I'm just really struggling to get this uterus to stay from me.
Yes.
Yes.
Absolutely.
So I checked already. It doesn't seem like she's bleeding from her tears.
Okay. No tears. This is acne?
Yes,
Okay.
yes.
Okay.
Yeah.
Peter, you're gonna be in a lot of cramping and pain right now because massaging super hard, trying to get these uterus to clamp down. Can someone get me some Cytotec and some Methergin out of the red box, please? Make sure that we have more Pitocin.
That's too much blood.
It's okay, she's gonna be fine. Peter, I need an extra IV, a second IV,
Deep breath.
IV fluids going.
See, I knew she should have had me in the hospital.
Medicine, okay? It's okay. It's okay.
She knew.
Thank you. That one of the IV wide open, the bowl is the pit, please. When she in there as well. Do I have that Methergine or Cytotec yet?
The 20 minutes right here.
Okay, perfect. What do you got going? Methergine or Cytotec?
Methergine.
Okay, you go ahead and give her a dose, I am. Thank you. Zakita, it's starting to clamp down, sweetheart. I just need you to keep breathing for me.
Deep breath.
Your vitals are fine. We're just gonna keep massaging. I know that's a lot of cramping. It's slowing down, okay? It's slowing down. We're probably gonna need to give her some blood after this because of all of the blood that she has lost. But at this point, I'm just worried about getting her to slow down and then we can do the other things that are needed, but she is stable. Okay?
I faxed records with all of the blood information, so the blood bank will be perfect.
Were there any tears during?
No, I feel like maybe just, some skin breakdown, but
Okay.
nothing serious.
Well, that uterus
Yes,
is
it's
down.
fine, but she did push for a long time.
Okay.
If you wanna check on
So the acne is. You are doing absolutely fine, sweetheart. We've got you stable. That medicine is working. We're nice
How's
and
our baby
firm,
doing?
okay?
He's doing good.
I'm gonna go ahead and take my fingers out of your vaginas.
We're gonna bring the baby back to you as soon as we can, okay?
Okay, you're doing great. You are nice and stable. Yes, I am ready. Go ahead.
Your bolus is finished. Do you want a second bolus?
Perfect, yes.
Okay,
And this one, you don't have to put you just put 500 in.
okay,
We have this other one going wide open. So we are good.
it's on.
Everybody's stable, everybody's fine, okay? Zakita, we're gonna just get you moved over to a bed, get you comfortable and cleaned up. And then we're gonna end up checking some labs and make sure that we don't need to transfuse you any blood or any other blood products, okay? Are you okay, sweetheart?
Yes.
Okay, good.
No, what's going on?
Tell me what's going on, Zakita.
My tummy hurts.
Well, that's because we're jumping on it.
Yeah.
That's expected, and your uterus is starting to really clamp down now. We've given you a lot of medicines to help with that. So now that it's contracting what we call tetanic, where it won't stop. So that's why you're hurting like that. We'll give you some pain medicine. Do we have any Toradol in them?
Yes, we do.
Okay, love to give her 30 of Toradol IV.
You're doing good.
You're doing great. So we'll get you some pain medicine, okay? That bleeding has stopped. We are stable, okay? Yeah, it has stopped. You're not having any more issues, okay?
Just some family history. My mom, my deal election, because she did, need a blood transfusion when she had her. So there is some family history.
Okay. Taria, will you take care of Zakita and I'll go talk to Mom?
Yes, absolutely.
Thank you.
Seems like we're really slowing down. So we probably can take a break from this, take a little break. We'll get some chugs and change out some of the pads so we can weigh our pads. You doing okay, Dad? Yeah, she's doing good, baby's doing good. You can always go take a peek at the baby if you want, or you can stay here, whichever you choose.
So I've got to get her some Toradol right now. Now that she's stable, we'll keep both IVs going, the fluids going, I'll get some labs on her. And when those labs come back, you're doing okay.
I know this wasn't in our plan,
But this is why we
this is why we have the hospital, this is why we have these resources. So that when we need them, they're right there. It's gonna be okay. Okay, let's get these changed out so we can help weigh the pads for Dr. Collins.
I'm hopeful that we're.
Okay, Zakita, I'm gonna have you just lift your bottom up for me so we can switch these out. Okay. Okay, lift up for me, lift up. Okay, good. I'm gonna give you these pads to weigh. Here you go.
Okay, so much. You're welcome. Okay, sounds
Okay,
good.
see a little smile, that's a good sign.
How we doing over here?
We're doing good. I changed out the pads, we're weighing to see what the blood loss is.
Sounds good, sounds good. And I talked to her mom and we discussed the possibility of a blood transfusion. She said that she had an allergic reaction the first time.
Okay,
So I told her in the event that we need to give her blood, we will pre-medicate with some Benadryl and Tylenol to try to prevent that. But I told her we need to get some blood counts going.
okay.
Zakita, honey, how are you feeling?
I feel a little bit better.
Good. Do you
Okay,
want your
good.
baby to come over and visit now?
Come on, baby.
Yes.
Okay, why don't we bring your baby
I'll
over?
check on lab and see why they're not here yet.
Okay, perfect. Thank you.
Here come baby.
Tally, can you all also just have them type and cross for 2 minutes just in case? Sorry, Dr. Davis.
So mom, dad, I'm Dr. Davis, I'm a pediatrician. Baby came over, baby was a little bit cold. We got baby all warm, right? Baby's strong, breathing on his own. We're doing great, okay? All right, congratulations.
I'm so proud of you. Does anybody have any questions now that we're stable?
How long
will she be here? Will she have to be here?
Well, it depends. It depends on what we have to do to her. Now that she's stable, of course, we would want to watch her for at least 24 hours just to make sure that she doesn't start bleeding again. As long as she is stable, she may go home at that point. If we need to give her blood, you usually give a unit of blood over 4 hours to try to diminish that reaction you were talking about. So if she were to need a unit of blood, that would add 4 hours. If she needed 2, that's 8 hours. So if we give her blood, I would want to watch her 24 hours after that's done, just to make sure that she's safe and stable to go home, so you don't have to bring her back. Just be here for her. Let her know that you're here. I think having Junior here is very helpful to her. Shankita, do you have questions?
None right now.
Okay. Is there anything that you need? Is your pain getting better with that Toradol?
Yes, it's getting better.
Okay.
And you let us know if you feel any big gushes so we can keep checking, okay? I'm gonna do another rub just in case.
Okay.
Brace for that. I know you're tender. You okay?
Oh, yeah, that's really slowed down now.
Good.
That's looking really good this time.
Okay, you okay?
Yes.
Okay, well, now that you're stable, we're gonna step out for a minute and make sure that lab gets here to draw your blood.
They're on the way.
And we'll just give you all a few minutes. We'll be back in a few minutes to check on you. If she has any bleeding, any gushes in between her legs, any sudden onset of pain, would one of you all please hit the nurse's button?
Yes.
Okay, we'll be right outside at the nurse's desk.
Thank you so
All right,
much.
Sandy, I'll be right outside.
Thank you so much. Yeah, you did such a good job. Wonderful. Woman. Are you? She do. You clutched
It was like, all right, y'all. So, debrief, any questions, comments, thoughts, and come here, love, since you, come on over this way. You. Me? Yes. Oh, we're live on the Hood Talks podcast. Say hi to the world. Yes, I want you to talk from here so we can. I got you. We the audience. I'm ready for my please. She got a comment.
So, having been in situations like this many times, I think, the communication was great.
Yes.
The fact that the doctor was calm as the leader of the team to facilitate what was going on. She asked questions and she is the person who led what was going on. She delegated, she made comments, she checked in on everybody, and in situations like this, where it can be, really crazy, where the mother doesn't stop, let's say move on and flying us down the hall to the operating room, the leader needs to be the one that has a full head. Because if the leader is frazzled, then the rest of the team is like that. I think it was great communication between the midwife that was coming from the home birth midwife, right? And the fact that I heard when I was in the room that you guys, they have a system here where, information is faxed ahead of time, there's a plan in place, so that if there needs to be a high level of care, it's not fragmented. And that's very, very important, especially considering that in this community or in the whole area, there are situations where, like you said, a 90-minute or a 75-minute wait to get to the hospital. Like, I can't even imagine what that's like, right? Coming from a big city where I work and live. And so that's very important. I even saw last night on TV that there was a white couple. The wife was a nurse and the husband, I forgot what he did. But she was having her baby, and guess what? Had the baby in the middle of the highway, in the middle of the night, baby wasn't breathing, and they had to basically resuscitate their own kid. And so again, and this was a white person, and it was saying, maternity tests, what about the people of color that are out in vulnerable areas? And so, and it just happened to say the 911 person that actually talked the two parents through it, because he had no blanket, he had nothing to basically wrap the baby with, so he went to his trunk and got a sweatshirt, because that's the only thing he did. And they said, so the news reporter was saying like, wow, this 911 person seems so calm. Well, guess what? This is the third time they did this in a week. So this is something that's prevalent, I would say, in the area, or basically from what the news is covering. So I thought it was important that, you know, I like the cohesiveness that you guys have a system in escalating care. And that's crucial.
That is crucial. I don't know if anyone has seen what the map looks like of the current maternal care desert, but it looks like a horizon map. It is that much red, especially in the rural areas of just nothing, of nothing. And so even when working with people like that, I always prepare them for like, okay, I know we're going to a hospital to have a baby, but what if? What if you have a baby at home? What are you prepared to? Like you were saying, he didn't have anything in the car. That's a no-go for me. We have a car bag that has towels in it, that has a little suction bug in it, because even though I'm not a medical professional, I do understand that babies get born on the side of the highway all the time. And the last thing I want you is unprepared. I'd rather for you to have it and not need it than need it and not have it.
Yeah, we get calls all the time in the hospital. Like, you know, as a hospital, we're just sitting where, you know, go to deliveries, sometimes, you know, we're ready for that. We get the call, oh, such and such happened at home. The baby is, you know, born, breathing, okay. Like, we'll get a report from like EMS, right? So they're driving in the car. We don't know anything till they come to the actual hospital. And if we have EMS actually come in, then we can get a report on these are the vital signs. This is what's actually happened. We're bagging the baby right now. Please meet us in the ER. And there's like a go bag like that's ready to go, where we can actually like assist with the airway. We can like, you know, back here and do whatever we need to do in the ER so that we can get upstairs, like to either the nursery or to the ICU. And so we're usually prepared for that. And we know if the baby's born at home, a lot of times the biggest thing is if the baby is warm. Because that's what, like, a lot of times if the baby is not, if the baby is not warm, it can affect our heart rate, our respiratory effort, it can affect all of those things. So keep the baby warm as much as possible.
So I just wanted to add to your point that EMS is really important in bridging that gap of communication from home to the hospital. But even more importantly, if the professionals are there in the home and they know the history and they're prepared to communicate. One of the biggest problems is people don't have the access, midwives don't have access to practice. Like, I'm from Illinois, and just now they're starting to try to license CPMs. But previously, CPMs were criminalized in Illinois. So I have CPM friends in Illinois, and when I was working at the hospital as a nurse midwife, they would call me, but they weren't able to come because they didn't want to go to jail. So because of those, we just need to change the policies. Midwives shouldn't be going to jail to try to help people save people. So one of the most important things is the communication, bridging the gaps and making sure that we are helping lobby, we are helping midwives get licensed so that they aren't afraid to step in and give the proper report and give the information that they need so that people can stay safe.
Let's talk the critical access hospital. So you talk about the 75-mile example that you gave. So a lot of our critical access hospitals don't have OBGYNs there. I mean, a lot of times, even the people working in the ED don't even have ED credentials now, so you know that. So how are we, as a forum, how are we working with critical access hospitals to make sure that they have, you know, nurse midwives and the appropriate staff to know to do all of these things? Because, you know, I work at Mercy and I hear all of the stories where the babies, you know, are in these rural areas and they don't make it. The mom, the baby, all of the bad, tragic stories. So I think some of these critical access hospitals need help too in understanding, and they don't look like us.
Well, I think part of the issue there is, we were talking about it before we started the simulation,
Part of the issue, and the reason why there's no OBs in these rural areas, because it's, as the OB and Dr. Davis and I were talking about it, if I'm in a rural area, now if I have this situation happen, am I taking care of my baby? Or am I taking care of my baby?
Yeah.
And that's a problem for OBs. And with the malpractice that we have, we are responsible for your children until they're 21. So I tell my patients, I'm responsible for your child longer than you are. You kick them out at 18. I got them until they're 21. And you're not sue me until they're 21. So most OBs are not gonna put themselves in that situation where they have no help. So that's why you have no OBs in these rural areas. I personally think the answer is midwives.
Yeah.
I think they need to
Yeah.
hire midwives. You cannot be a critical access hospital and not have someone who is at least able to resuscitate and move you down the line where there is a need. So I think it's super important. If we're gonna lobby, we should be lobbying for our supportive APPs and nurse midwives to be in those places in rural areas to accept that and have the knowledge. Because the ED doc don't know.
No.
They don't know. EMS half the time, I heard you talking about EMS. He felt good because he had done it 3 times a day. Well, most EMS come in looking like the dad. So I think that's the answer to your question, is that we should probably be lobbying for safety with APPs and nurse midwives in these rural areas.
Ask the state of Missouri to, license CPMs, like, right? Being a CPM student is hard. Money spent, hard hours worked, and I can't have a license in the state.
Right. I just wanna say, while y'all talking about lobbying and policy, make sure y'all stay to the end today.
Yeah.
I'm closing out, and that's what I'm talking about.
Right.
Okay, I'm talking about political engagement.
I hope everybody signed that abortion petition.
Yeah.
I'm talking about it.
Okay.
We don't talk about it. We don't talk about it.
Well, that is.
So as proud of that, I want to say I think it was. On a serious note, I think that, one of the steps that we do need to be talking about is, okay, sorry. So one of the steps we do need to be talking about is, organizational collaboration, right? Because before we talk about advocacy, we're stronger in numbers, right? And I think that for a long time, and we can talk about this as MBNA, right? Nurse midwives haven't really necessarily felt a part of nursing associations because they get left out to dry to some extent, right? And it's time that we heal that and bring that together. Because it seems like this is a multi-system problem / multi-system failure.
Yes.
Right, like they're telling me that OBGYNs need to have partnerships with advanced practice providers and midwives, right? Both nurse midwives and professional midwives.
Yes.
So it means that we need to come together and get to a table and work out plans so that then we can go and use all of our full political power
Yes.
to advocate for some of these things. So I'm hoping that we all get to the table at some point to draw up some of these plans so that we can start advocating. And I'll bring it back to the national.
And I would make sure that pediatricians are a part of that conversation
Please.
too.
Right.
Because there's a huge, the diet is very important, right? So one of the leading causes of infant mortality is something that was complicated with moms, right? And so with the same critical access hospital where they're bringing mom, they just brought a baby. And if it's a healthy baby like Julian, right? then they're fine, right? But even if you had like a 32-weeker, right, that was born and brought there, right? 32 weeks at, St. Louis Children's, we're like, we're good, we're golden. Right? Like this big, healthy, nice baby, right? But then if you're 32 weeks and you're in a place where if something goes wrong, if your blood sugar goes down and we can't put in a central line, we can't get IV access, if we start actually coding, right? Who's trained in neonatal resuscitation at that place, And transport, that's 75 miles or whatever we said. That's a long way for transport to get to.
And to your point, when I was talking about OBs being scared of this, it's not just malpractice. When I was training many moons ago, we actually had to rotate through the NICU as a resident and learn how to resuscitate newborns. And you spent months in the NICU like you spent in the adult ICU. Now the residents don't have to do a NICU rotation. They don't know nothing about resuscitating babies. They have completely separated that, so we need you. That's why I said it's important to have somebody else, because the OB isn't going out there by themselves without somebody to resuscitate that baby. And most younger OBs wouldn't know how to resuscitate the baby if they had to.
I will say this, locally, we have, BNA and MBNA have policy, teams that we work with, and I don't know what you're gonna talk about later, but Dana, who is on staff here and is our policy chair, organizes us, it's BNA and STL, to go to Jefferson City to lobby about things. The most recent thing that we've been talking about is this, regulatory reduction for APRNs. So it is on our radar, and we are talking about it, and we are, having these kinds of conversations.
So I work with high-risk maternity. And a lot of the times, yes, we see the complications during delivery and things like that while pregnant. But one of the things that we run into a lot is the postpartum, where a lot of these women are being shipped out of the hospital too soon, and then they have strokes. A lot of my patients have had strokes, they have died, the children died at home. And this is within the 6 weeks of being postpartum. But they don't have the assistance. Are the midwives following some of these? I mean, do they follow after, or?
That's why we do this.
Go ahead.
So, something that I know ACOG and also ACNM in the past years have really tried to reduce, not missing things in those 6 weeks, because traditionally you would get discharged from the hospital and we don't see you or talk to you again until 6 weeks. So some of the changes have been made recently saying that, like, you need to have a nurse call 2 to 3 days after they leave. You need to have a visit at 2 to 3 weeks, and then you have your 6 week visit, because too many things are being missed in that time frame. 6 weeks is a long time. If your baby's already a month and a half old, by then breastfeeding is done because the support is gone, and all kinds of issues can arise. So that's one of the most important things, is being able to touch. And home birth midwives come to the home to do care, because that's a big barrier for people. They don't have childcare. They can't drive themselves because they don't feel well. So community birth is one of those important things where people are coming to you to make sure that the gap is closed, so that you can't say you didn't show up to your appointment, I'm coming to your house. So
I have that going on right now in the hospital. I had a patient that had blood pressure of 168 over 110 this morning. Yes, because she fell home. And my answer is no. Now, today is post-op day 4. She had C-section for twins at 33 weeks. So today's post-op day 4. She's like, but today's my day to go home. I have a 3-year-old daughter. She's really missing me. I really want to go home. So a lot of times it's the patient pushing to let them go. Now, I know my patient. This ain't my patient. This is one of my partner's patients. I don't know your reliability. I don't know if you got a blood pressure cuff. I don't know if you're compliant. So my answer to her was, as badly as you'd like to go home, these blood pressures are severe range. I absolutely can. Now, we got her on 2 different blood pressure medicines, and so we thought we had her until this morning. So I said, no, I need at least 24 more hours to mess with your blood pressure medicine to see how you respond, and I might be longer than that. So a lot of times it's the patient who's begging to go home for whatever reason, okay? If they're not severe range pressures and are less than 160s over 100, if it's my patient and I know you and I know you have a blood pressure cuff and you're reliable, I tell you I need you taking your blood pressures at rest twice a day. I need you recording them. I need you to send them to me through your MyChart on Monday. If not, you need to call me, and I need to do a telemedicine with you on Tuesday.
Yeah, I was gonna share, so as a doula, and I heard you mention like in those cases where, you know, if someone does have a home birth and they aren't having those visits in the home, like our role in that. And so I think kind of like you could even see in the simulations, a lot of times the doula's role is real holistic. There were different points where you could see, yes, we were supporting the mom, but we were supporting grandma, we were supporting the dad, making sure like everyone's okay, they understand what's going on. And like Kyra was mentioning in that pre-planning, as doulas, it's a wider spectrum. And so during pregnancy, we do talk about postpartum and planning for that. And I know for myself as well as many of my doula sisters, we talk about those postpartum warning signs and many of the things that they review at discharge, but at that point it's a lot going on for the mom. So we talk about it prenatally, and I know even for myself in those prenatal visits with the support people, the blood pressure example that we're talking about is actually something that I role play with all my clients. It's like, okay, let's pretend we home. So it's a couple of days after delivering, you're having these symptoms, and I ask their support person, how would you respond? What would you do? What, you know, like, and go through like, oh, I watch the baby so they can take a nap. And I'm like, okay, so if they take a nap and they still, you know, then what? And, you know, and I even role play like, what happens if you call and you're told, you know, oh, wait and see what happens. And, you know, I literally, and many doulas literally practice. And that's part of that advocacy piece and making people feel confident to speak up and go and know that,
You
hey,
need to know what
go.
to ask, right?
Yeah.
If you've never even, I tell my patients, if it ain't been you, if you're not, haven't been that woman, you're not supposed to even know these conditions exist.
Right.
But when you become that woman, you're free falling. You don't know what's happening to you. I didn't even know this existed. I don't know what to ask. So I think the preparation beforehand is super important.
I was gonna say, also from a doula's perspective, first of all, when I take clients, I hate to say required, but I ask them to have a blood pressure cuff, a birth ball, a list of support people, and then I need like your emergency contacts, right? And we also get a whiteboard. And so the whiteboard, it has like, it's half and half. Over here is tasks for people to do when you come visit, because I don't need you to hold the baby, I need you to do all these things.
Okay.
And over here are, is mom sad? Is mom woozy? Is mom, and we just go through a whole bunch of things. And usually they're like more related to like maybe something happened in her delivery, but I cover anything that would like show signs of postpartum preeclampsia. And at the bottom it says, don't call me, call the hospital, right? Or go to the hospital. And I also, in my postpartum visits, not postpartum, my prenatal visits, I have one where I'm going over signs of a PowerPoint, a whole presentation. We're talking about everything that you can expect that can go wrong at the end of pregnancy. We talk about postpartum hemorrhage. We talk about interventions. We talk about every single thing, so that they have like a good idea before. I want to educate you about these things while you're like calm and you're in a good space, instead of you're at the hospital, you develop preeclampsia and you don't even know like what's going on, what's happening to your body, why it's happening to your body. Then also for me postpartum, once I leave the hospital, I typically don't go back unless my client has like a couple days stay. But that first day they come home, I done beat some of them home. And I'm sitting outside their house waiting for them to come in. So let's come in, let's make sure your whiteboard is good. Let's make sure your support team that's here knows what we need to be doing. And I'm running back through with their mom or their husband or whomever is there, like, okay, now make sure she starts talking about she's tired and she's this and she's dizzy and, you know, all of that, she feels faint. Y'all need to go back to the hospital. Don't wait for somebody to tell you to come into the hospital. Just go. Because once you're there, they bare minimum have to look at her. They're gonna do some labs. They're gonna take some urine. They're gonna put on a blood pressure cuff. So force their hand. You know, don't call because they don't know. And one more thing, because Ebony just said something about her going to take a nap. I tell everybody, if she sleeps more than an hour, please go check her. Go wake her up, get her some water, get her to walk around. Because what can happen and what has happened, what does happen, as we know, is women will have strokes or anything in their sleep, and then they're gone, and you just like, you think she getting a good nap. And so those are things like, I hate to say I force families, but I force families to be engaged or get out.
Yeah, I
Or
agree.
go home and we'll see you in 6 weeks.
That happened to me last week. A husband called me in the middle of the night, said that his wife had a headache, and I hate it when husbands call me. I'm sorry. Because unless she dead or passed out, why are you talking to her? I need to speak to patient. I need to talk to her because she can answer my questions. And he's like, hon, she wants to know. I'm like, just put her on the phone. So he called and she had pressures of 160s over 100s. I told him to take her in. He was like, okay, we'll go in. So then I get a call back about an hour later. It's her. Well, I took a hot shower. I took some Tylenol. I feel better. I'm like, you really need to go in. Your blood pressures are high. So I'm waiting. I'm checking my phone, checking Epic. She doesn't get there. The next day, I'm off call. It's Monday. She comes in with pressures of 190s over 100. Luckily, she didn't stroke, but then it looks like, oh, and then she's in, the note says the patient came in to finally get all of this under control. I'm like, I told your ass to go in. I feel like I'm the one. When we start seeing patients every 2 weeks at 28 weeks in the third trimester, and then at 36 weeks, we see them every week. So at the beginning, they're like manufacturing questions to come up with. And I'm like, you don't have to do this. We have 13 visits together. There's no reason for you to be asking me delivery questions in your 12 weeks, right? So I go as it is appropriate. When we get into the third trimester, I automatically tell them, I'll flip. You're coming to see me more frequently because this is where bad things happen, right? High blood pressure, diabetes, preterm labor, cholestasis in pregnancy. My growth fell off on my baby. Now I'm the 8th centile and I was the 25th centile at 20 weeks. All of these things happen in the third trimester, which is why we see women more frequently. So I tell them that when we hit the third trimester, and every 2 weeks I hit them with a different topic. Because then I'm not overloading and you're not under stress. You're not in the emergency situation. But this week we're gonna talk about the signs and symptoms of preterm labor. Next week I might talk to you, next visit I might talk to you about the signs and symptoms of preeclampsia. The following week we've gotten your sugars back and now I'm talking to you about, you want a diabetic, but you probably make these last changes to make sure you don't have a big baby, you wanna have a vaginal delivery. So for me, it's pacing, giving them information where it's appropriate along the prenatal course.
Oh my God, I wish I had you.
That's why you got all those patients. We have stuff that's.
Yeah, I know you had for your comment, we're gonna take people for the next scenario.
I do have a comment. So coming from a state that is not abortion restricted, right? And I know that this state is, and.
Right now.
Okay, all right, so right now.
Right.
But knowing this, right, we know that maternal death is from the time somebody is, maternal death can be from the time she's known to be pregnant up until 1 year, right? And so if we're in states, or there are states in this country that women are dying, I mean, I'm sorry, but the person in Kansas City, there is no reason why she should die from sepsis. None whatsoever, and we don't even have to go there, right? However, that's a prime example of the numbers that we are going to be beginning to see, because people think that if somebody has an abortion, it's because someone wants to get rid of their baby. And many times that is not the case. It's because the child is not viable, there's anomalies, et cetera, et cetera. And so those are the things that we really have to be cognizant of. We're going to see a rise in these things because of the laws that are being made in this country. But I just want to ask you, Dr. Collins, as an OB, what do you do?
Well, first of all, I mean, one of the things is when people actually have a elective termination, like first trimester, they don't call me first.
No, what I'm saying,
They're not consulting me about that.
Let's say somebody's 15 weeks and they just brought you.
Yeah.
Right? And
yeah,
you gotta do D&E, you know the baby's.
Well, luckily, I'm not at Mercy.
Okay.
And Mercy can't.
Gonna use his video,
because
I can get a better angle for the way they
But at the other institutions that are not Catholic in the city, we absolutely can do it. I do have colleagues. And they're here to do it. I may put them on the floor. We're not sitting in the we have to be on the floor. So we drive advice. There are a lot of people that will induce a mom for an IUFD at, in the second trimester.
Before you leave. All right, we got you. Okay, y'all ready?
Mhm.
All right. What's the height of it? It's a Sakita.
Sakita, okay, look, it helps.
Yeah. So we got it, ready, and begin.
Good morning, Zakira. My name is Dawn Patrick. I'm one of the therapists here today. How are you? How you doing, Dad?
How you feeling?
Good. How are you guys? I heard that it was kind of a traumatic birthing experience for you.
It was, we had some bleeding afterwards.
Okay, how you feeling?
Be honest.
I'm not really sure how I'm feeling.
Dad, what do you think? What have you been seeing?
I think she's depressed. I think that she went through a lot. It was very traumatic. I know it's traumatic for me to just look at it, so I can only imagine what it was for her. But she won't talk. She don't want to talk about it. She stays in bed. She's protective of the baby, right? And I just think that, I want her to talk to somebody or get help. I don't know what's going on.
I think all she needs to do is pray, and we're gonna pray over her. I'm gonna have the pastor come, and we're just gonna believe God that all is well.
We're gonna pray you get a different perspective.
Not today, not today.
We're gonna pray.
Is it okay if I sit?
God is good. He'll take care of this. He'll take care of this. She don't need you.
But it is a little bit of depression is really real, Mom, okay? And as a new mother, there
just
are
believe
things that
God
happen
will
that
take
you have
care of
to
this.
think about.
Just believe God.
Consider getting some additional support for you and your husband so that you guys can talk about the things that you've experienced. It's okay to talk about these things. It's okay to have the feelings that you're having right now. Okay, but it's very, very important for you, baby, and your family as well, for you to get some additional support, whether that's counseling, there's medication sometimes. Have you been experiencing a lot of crying and
Yeah, sometimes I just go in the closet and cry.
any thoughts of harming yourself or the baby?
Pause. I hate to say it.
They never seen us.
They never seen it.
Oh.
Yeah, far from the top.
Oh, dang.
Well, now, and I got you on film, but they see.
Also,
Start over.
since your back is to the camera, why don't you sit right here and I'll move this chair over here.
Okay, I mean, we're gonna stay. There we can do. You want to the baby? Since she don't want to take it. Exactly, but you too. Okay.
And I'll get it from
Okay.
This way you can.
It'll be a sign. You're trying to get the baby and she goes pull back still. And that can show.
That work, yeah. And after you come in and introduce yourself and get out, like, give me the baby.
Okay.
Let us start here.
Let me check, make sure it's up and running. I was trying not to laugh. He said, I think you need to find another. And I'm like, I'm supposed to say professional. That's what my doctor said. We can pray about it. I'm
Good morning, Shakita. My name's Dawn. I'm one of the nurse practitioners and therapists here at the hospital. How are you today? You Dad? How are you? Hi, nice to meet you. What's your name?
JJ.
JJ, nice to meet you.
I mean, I just been feeling, I don't know, to be honest. I'm not really sure.
Okay.
Just the way emotion.
I just thought that she need to pray about. I'm gonna have the pastor come over and we're just gonna believe God that all of this will pass. This too shall pass.
But it is some signs.
All she needs to do is the scripture. It's the scripture we can meditate on.
But it is. Mom, is it okay if I talk to her? Just her and I?
Anything could help. I just think that all we need is to believe God.
I understand.
I hear you, but we're listening to
Is it
you.
okay if I sit with you for a moment?
We're listening.
That's a sign right there, therapist. She don't want nobody to hold her there.
Have you been experiencing a lot of crying or?
Yeah, I just go in the closet to cry.
Okay, JJ says you've been in bed a lot. Okay. Have you considered talking to somebody about it?
No,
Have you been having any thoughts of harming yourself or the baby at all?
not the baby, but sometimes I just be feeling blank or just like I'm floating and I shouldn't be here.
Okay. You've had a very traumatic experience, and it's okay that you have to note these feelings and experiences, okay? What I would encourage you to do is to find a therapist that you can speak with. Are you willing to do that?
I am.
Okay. And then sometimes past therapy, we might have to start you on medications if you feel like the depression is lingering a little bit longer. A postpartum depression is very, very real.
Whatever it takes for her to help, she needs help.
Let's say this can be talked for later. Let's listen to the therapist. Okay. Are you willing to do that? Okay. Is it okay if we set you up an appointment and maybe over the next day or so, you can come into the office and we can start just having some counseling sessions to debrief and start talking about your traumatic experience?
We can
Okay.
do that.
Are you willing to do that?
Yes.
And she's also been having other symptoms that she's not mentioning, and I wanted to talk about it.
Okay. Tell us about it.
She's been complaining about headaches.
Okay.
Tell her what's going on, babe.
Just been getting really dizzy. My head's been throbbing. I have to sleep with the lights off. And then sometimes my patient gets a little flu.
Okay, any ringer issues? I see you guys have a blood pressure cuff over here. Is it okay if I take your blood pressure? Okay, let's see. Sometimes we have something called preeclampsia, okay? And we did go over that in our prenatal visits, but she's just different right now, just not herself, her usual self. So cross your legs for it. Oh, girl, your blood pressure is 179 over 100. Okay. So what I'd like for you to do, hon, we're gonna probably have to take you to the emergency room so you can go get your blood pressure checked out, okay? So you really is. Okay, because you had some bleeding before, let's show you how sweet. Yeah. You had some bleeding with your pregnancy during the delivery, correct?
I don't think this is necessary.
Okay, let's go. Let's go.
I'll be okay. I'm just.
Girl, don't worry about that blood pressure, girl.
If you get some time, you could call Pastor.
Yes, definitely, definitely. And that is my thing with the like this, you get the baby, we ain't wrap the baby right.
And it's like, girl,
I don't know if y'all read about the patient a few years back that killed herself, her husband, shot her dog, and killed her baby. That was my gift. She did not call my office. I had no idea that this was going on. And all the comments in the papers and nationally were the OB, the OB, the OB. And I'm like, the OB didn't know. She did not reach out to me at all. And she was way beyond her 6-week postpartum. I saw her for her 6-week postpartum in November, December, and she did this to her family in March. Wow. This patient was a social worker. She came in my office for her 6-week postpartum after a vaginal delivery, had her makeup on, looking beautiful, in charge of her life. And all she talked about that day was breastfeeding, okay? 2 days before she did this to her family and herself, she was at a family gathering with her mother, her stepfather, and her in-laws, and all of her best friends. Nobody at that family gathering was aware that she was having problems. They knew that she was obsessing over breastfeeding, but when I saw her for a 6-week postpartum, breastfeeding's going great. I'm making this much, I got a freezer full, and she talked to my ultrasound tech, and they, shared some breastfeeding tips, and she was like, I'd have to come and feed some well one. So that was back in the fall. And then we fast forward to March, and her friends and her family at that gathering all were just like, well, she just kind of talked about breastfeeding and going back to work and how to keep her breast milk supply up, but that was it. They were with her all night, dinner, drinking, had no idea. That was Wednesday night. Friday morning, Thursday, she bought the gun. Friday morning, she killed her husband, the baby, shot the dog, and killed herself. Her in-laws found them that afternoon because his work called the mother, the paternal mother. His work called her to say that he had not reported to work. She and her husband had a key to their house, and that's why they went to check. They found them, and the only one alive was the dog. So this is super important for the people that are around. I'm not there anymore. If you don't call me, I have no idea what you're going through. So because of that, now I do telemeds to just check in before the 6th week, especially if someone is on meds, if there's a history. I do it more frequently with first-time moms than I do with multips, And the reason for that is I think one of the things that we really don't address on a first-time pregnancy is nobody warns you that you're not going back to you. You're never gonna be that woman ever again. And these women need to understand this. So I think the postpartum depression is not just depression, it's grief. You are grieving for the body that you're never gonna have. You're grieving for the fact that you cannot just pick up your kids and walk your ass out the house. And then when you do think you're on time, and you get your baby ready, and then you got over everything. So, this is important for us to recognize that the people that are most important to me and my treatment of my patients for postpartum depression and anxiety are the people that they live with. Don't make them feel like they're not being heard. Don't make them feel like, pray on it, you be all right. Sometimes there's a chemical imbalance, and sometimes it's more than just prayer. And if the people around you are just saying, pray on it, but not offering you any tools to get out of it, then it's actually more of a problem and not helpful. Because now they're gonna pull back from you. Because all you're saying is, you'll be all right, pray on it. Pray on it. You just need to go to sleep. You be okay.
Everybody like that.
Everybody goes through this. And you can tell them, I've gone through it, so-and-so has gone through it. But until you start giving concrete examples of how you feel, and it's the small things that trigger you, it's not the big things. We as healthcare professionals aren't gonna see those small things. That's the family, that's the support system. So if I have anything else to say about that, is also when the husbands come in, I go, how's she doing? Tell them. Tell them how she been sleeping, how she been eating, is she drinking enough water? I love it when they bring a support person, because she'll be like, I'm okay. And that's exactly what that patient did to me. And I still deal with that because I feel like I failed. And the public made me feel like I failed with all of the media coverage over it. But I'm like, I saw her in November, December, this was March. So she did a really good job of putting on the face. All right, Chair.
I have a question for those in the room. Do you know the time frame right now that we are losing the most mothers?
Postpartum.
I know postpartum, but how many days? How many days?
I don't know the answer. We're out.
42 to 100.
You're out.
Right?
You're past your 6 weeks.
You're past that time frame. So you're looking at 42 to 100 days postpartum. And the leading cause right now in this area is what? Maternal mental health. It's maternal mental health. So it's like suicide, accidental overdose, things like that. So there's not much my OB can do for me and the things that are going on in here. The people who can, my boss, right? My good friends, my partner, those people who are around, and we have to, it's really common in the Black community to pray about it, right? It's okay, we gonna just pray. Ooh, we gonna, Lord, okay, we just gonna cover her. Come on, y'all, let's touch and agree. And sometimes you need to touch and agree with Lexapro. You need to touch and agree with Zolon. That is okay.
The other problem is, don't keep family business.
Right, you keep, and that's I'm gonna tell y'all something. When I was growing up, my mom used to say, what happens in this house stays in this house, right? And so then, when I was younger and starting to experience depression as a result of severe grief, I couldn't go tell somebody, right? So that's something I had to struggle with until I was an adult. And we have to, as a community, stop that. Okay, there are no secrets in postpartum care. There are no secrets, okay? And a thing that I really appreciated is my partner, even before I had my baby, would tell on me. He would text Charity and be like, she having contractions. But that's so
helpful because if something would have been wrong with me, he would have been able to tell her, because when something was wrong with me, almost 365 days postpartum with my first son, nobody was paying attention.
That's right.
Nobody was paying attention. And we really have to be a community, right? We have to lean into community. And also those of us who are at birthing age and who are still birthing, we have to be able to allow community to show up for us and not say, oh, I'm all right, I'm good. You know, everybody goes through this. Because one thing for sure, yes, my mother probably experienced postpartum depression and my grandmother, and they never got help. They parented from that place of depression.
Right.
And so you look at it, oh, you know, I don't know what's wrong with y'all young girls. We didn't have those problems. Yes, you did. Yes, you did. You parented from those places. Don't share to do with me.
It ain't like Kyra has my brain. She literally said everything I was about to say.
Oh,
Really
sorry.
the same person. Couple hours apart, but here we go. I got you. Got you.
It's okay.
I'm gonna keep it short, but I just wanted to piggyback on what you were saying about, as providers, we're gonna see you in your whole pregnancy, then a couple visits, and then you still have a whole 10 and a half months after your 6-week visit that you are still postpartum. So every postpartum visit, I close with this: you're doing fine now, everything looks good now, but there's things that you need to keep track of. When you go back to work, that's when sometimes things fall apart, because you're fine when you're off work and you're with your baby every day, things can fall off then. And I always close with this: you are postpartum until 12 months postpartum. And I'd say it again, I am your midwife until you are 12 months postpartum. You can come back at any time. Sometimes everything's fine and people check on you 2 weeks, 1 month, even 2 months. And then after that, the visitors fall off, everybody falls off because you're doing great. So you have to remind anybody, it doesn't have to be the provider, anyone around someone postpartum, keep on reminding them that they are postpartum until 12 months. And even now, so they're looking at research to extend that to 24 months. Postpartum depression really can be up till 24 months.
3
And
months.
you don't know how many times I hear people say, well, now thinking back and how I was different, I had postpartum depression, I just didn't know it. Because in the postpartum brain, you're not experiencing things the same way. So it's all about the support system and people telling on them, like, no, they're not different. But they will say that they're fine because they are in survival mode. They don't have the vocabulary to tell you that they're not okay a lot of the times. So that's why the support system is so important.
I want to take a minute and segue. I don't know if many people know about Chestnut Health Systems. We're on the Illinois side. We do have a few hubs over here in Missouri, but it does not take care of pregnant and postpartum people. We are a resource here in this area. We partner with other, like Queen of Peace and Our Ladies Inn, and we support pregnant and postpartum women up to 12 months with substance use and mental health. So if you have someone that come in to your OBED, or if you have a client that you feel may fit, we are here to support the whole entire journey. We not only support pregnant postpartum up to a year, we also partner sometimes with DCFS. And if a child has been taken, for instance, the child has something in the system mother has, they go out and do the investigation. They come back and they say, hey, the child can stay only in these situations. Our doulas go out, we support the client there, we show up in court, we show up for family support. We can support the mother as well as the family up to children 5 years. So we are a resource in this area. Even if your clients live in Missouri, sometimes on Medicaid, we can get them stable inpatient care. We have detox facilities. We can't detox while pregnant, but we can detox safely, get them into those facilities of care inpatient, where they can have hands-on care from therapists. We have a psychiatrist, 2 psychiatrists connected to our pregnancy and postpartum program, as well as mental health counselors. This program has been on a grant probably for 6 years. Many people don't know about it. So we're just trying to get in the area as a resource. Call and see
We have one of our doulas over here, Poppy. She's a part of my team, as well. Just give us a call. We can do screenings. We do mental health screenings as well as substance use screenings. So we can comprehensively try to take care of these clients.
All right. You touched on something really important. You know, we're talking about mental health overall, but I think what we haven't talked about is the shortage of mental health providers. I can't tell you how many psychiatrists have filled their practice and they've had to close campus. We had one particular psychiatrist that was like, just call me directly and I'll get these women in. She retired. Like, it was so much because all she was getting was this influx of these women. So I think that's important, going back to the support system and, you know, organizations in society that will help, because there's a 6 month to 9 month wait for therapists. There's a 9 month to 12 month wait for psychiatrists. And that don't mean you're gonna like them when you go. And it don't mean they're gonna spend some time. They probably just gonna give you the script and say, see you in 2 months and let me know how you doing. So this is a real issue, and it's a time consuming issue. And it takes everybody from the family support system, and it just goes outward from there. Dr. Day.
I would just say, like, as we know that postpartum coverage has been extended to 12 months, we have to really think about like what we are doing to equip our primary care physicians as well. Because when do birthing people go from the OB care team, the birth workers, to from the birth workers to like back to like primary care? That transition has to happen, and it has to happen smoothly. It has to be warm handoffs, and they have to be equipped to see these things, to know these things, and to know how to care for these things as well, up through like 12 months to 24 months, right? Even because that mom and that baby, you know, they're going back to their family practitioner, especially like we're talking about Medicaid patients, like the most vulnerable patients who are back in their community health center, you know, and they have an appointment every few months, right?
To your point, I do telemed with my patients, and if I'm scared that they're falling off a cliff, you telemed with me every Tuesday.
Yeah.
Until I know you're okay.
Absolutely.
I start meds. If I have to go past 2 medications, then you're out of my practice. I'm not a psychiatrist.
Can I add something too? I'm sorry, I didn't mention it. Them not listening. I was a mom of 3 at the time, and I was letting the doctor know how I felt and what was going on, that I felt imbalanced. And of course, the first thing she said was what? My weight. She was not listening to me. She did not run the test that she needed. I didn't get the test that I needed to my 5th baby, after my 5th baby. So I want providers to also listen to the women. So if I'm telling you something is wrong with me, don't automatically look at my weight. Don't look at the nail that's in the middle of my head. Figure out what's going on with me.
I was just gonna say, when you talked about, when we were in the planning committee and we were talking about these simulations, like I got super excited, and to see it like in person, I cried. Like I was emotional because my like I feel like we need to see this successfully, right? We need to see this happen collaboratively. The team worked so well. Like I was just like, dang, like it's possible. And just because that happened to my mom, and like I think about like, what if that provider wasn't you? You know, what if that provider didn't care, didn't have the skills that was needed? She would have died. And and so we think about. I told him yesterday or last week at HRSA came and they talked about like moms and babies, and I said you need to think about holistic care. Because what about that child? What about the dad who would have had to raise me? What about the grandma who would have had to raise me had my mom died? You know, and so like it just made me emotional to see it. You know, my cousin also was a nurse, but you know, it made me emotional to see like it happened and that mom survived. You know, and
Well,
it happens.
I encourage my patients to bring their doula to appointments. I encourage them, bring your doula. You got a midwife, bring your midwife. We need to be on the same page with a plan before you can labor. And that's very important. That's part of that team. And to Talia's point, it's always about communication. I think you've been stressing that since yesterday. It's always about communication. Doulas, call me. If I don't answer, or my nurse says, can I take a message? I'm gonna call you back when I realize that you're working with a patient, that we have a mutual patient.
Yes.
I'm calling you back because you're calling me for a reason. So I think these things are important to your point, but the communication shouldn't just be in the emergency. You had a team before you got here. Did that team know who was on the team?
Right. That's it. Yeah, because clearly y'all knew about the shit.
Yeah.
Darn too. No, wait. That's how y'all, so, yeah, I'm in charge now. I got you, I'm pivot over to, so I got Dawn, and then we go to you, and then Alicia Vanna close out, because we're gonna head down, if I look at me, because then we're gonna have Camilla Barnes here, Dr. Camilla Barnes, she's gonna call us with the call to action, she's gonna close it back, and then Kyra's gonna talk about advocacy and what's happening in the state of Missouri. So I'll make sure we get that in. I love the conversation. I was gonna say I love it, right? So the part that I wanted to chime in on, because it's near and dear to me, is strong Black woman syndrome is toxic. I've had it my whole life. And you also need to get into the part that a lot of these things that we believe in is rooted in slavery. So like when, you know, and not talking about, you know, our elders, because you love and respect them, right? But the what everybody who's saying like, y'all knew mama just don't do nothing. I went back to work a month later, 2 weeks later. Again, you have a mentality of survival mode. That's not how it's supposed to be. You just had to. And so we suffered. And like Kyra said, a lot of people suffer so long in silence. As I always tell my clients, you ever think about it, you got a mean grandma? Yeah. Sometimes you got a real nice one, right? Yeah. And usually that mean grandma had a whole lot of kids. You think about it, right? She had a whole lot of kids. But what is by the time she got there, she done had so many kids, she never got treated for her postpartum depression, uterus prolapsing, falling out, all these things. Granddaddy don't understand. Nobody know. You know that grandma mean, right? You go over her house, that's the one you best. You don't even slam her door, you walk out, you. She looking, right? And somebody even supposed to figure that too. Everybody got that grandma. But again, we gotta realize, because then also we ain't gotta, just like what Dr. Thomas talked about the other day, like we ain't gotta be respectful, but we do have to educate everybody. We gotta educate our elders on what's happening now. Yes, that was your experience. Also, don't bring your birthday experience or your sister, auntie, cousin, to the birth, because that's their birth. Respect the partners. All right, so like y'all saw in the scene where Mama and Drew's kind of going back and forth, you gotta trust that if I chose this man to be my man, that I'm trusting him to lead and guide me. Now, if I'm with a fool, that's my decision. You got to let her own that you chose the one fool, all right? But if you got somebody who is trying and they trying to learn it, right? And also again with classes and bring them forward, bring the whole family. Whoever's gonna be a part of your birthing experience from pregnancy to that room to your postpartum, you gotta bring them to them classes because they have a lot to learn. Let me say one more thing. Yes, ma'am.
I always tell my patients in the office, the precedent you set with your first child is the precedent for the rest of your life. So for women that go, I got it, you can go to sleep, he go back to work in 2 weeks. No, he needs to be doing something. Period. You didn't have this baby by yourself. Period. Well, I'm breastfeeding, well, make his ass get up, change your pants, get the baby put it back to sleep. Come on, like it's a team. They give you the time off to do those things. Well, I got some men that are getting more paternity leave than my patients get. So, I mean, there are some organizations that will there are some organizations in town that are giving dads 12 weeks paternity. And I still got people, especially in the medical field, who have no paid paternity leave and have to use their ETO and PTO pay and go back when it's over. But to the point is, you have to, whatever precedent you set, if you say he ain't gotta help you, then he ain't helping you on the first child, second, or any other children, because you told him he didn't have to. So there's always something that your partner can be doing, whether you're breastfeeding, whether you're bottle feeding, there's always something you can be doing. With my second, when I was in residency and I was gone 36 hours at a time and I breastfed. And my husband would get up and, like I said, he would change the pamper, go get him, bring him to me, I would breastfeed, he would burp, get him back to sleep. So then when I'm gone for 36 hours, he ain't like, what do I do? He already know what to do. And when the breast milk
run out, it's some infidel in there. So he knew she ain't gonna be home for 36 hours. I can't call her. She ain't coming home from surgery. So he was in a different position.
Yeah.
And he took that very seriously. And I think all partners should. And most of them want to help. We tell them they don't have to.
All right, so we got a quick question down there, Dawn. Speak real quick about substance.
Yeah, so I do have a question, for the doulas. How are the hospital systems responding to you guys? Are they receptive?
Great
Do they
question.
let you guys come in? And be a part of, do they, when you speak of the classes that they're having for women, do they let you guys come in and introduce yourselves and say, hey, this is a component that is very necessary? How is that going for you ladies, and maybe any gentlemen are doing, I'm not sure, but what, and then on the back end of that, what do you think we need to do as a group to make them aware if they're not? Because this is great that we're here in this forum, but it's a whole society of people out there that have no clue, none.
Run that, Nelly.
So I started in 2016, and so
OG Duke, stand up.
I would say that the environment now is a lot better. I think I commend nurses. I think nurses have been like the biggest role, or has played the biggest role in changing the dynamic. However, there are some old school minded OBs. And some old school minded nurses, like the older nurses, not to be, ageist or anything like that, but like you can tell the transition. You can tell the nurses that have had spin the babies training. You can tell the OBs that have had those trainings. You can tell the OBs that actually understand that you're helping, the doula is helping. But I've also seen OBs that are very ridiculous and they don't acknowledge, but I'm different. And I know a lot of the doulas that I've trained understand that you introduce yourself to that nurse and you try to create that environment, but also your client and you have confidence to understand your scope. And so now the plight is very different. I love SSM and BJC. I also take clients over across the bridge, and so that's a little different, but it's
I'm
still
working on it, man.
I know. Listen, Charity, when I tell you, I'm always name dropping, but I would say what needs to happen, a lot of times the clients that have had trauma being done to them from OBs and nurses, they have been able to make complaints. Sometimes they are followed up on, sometimes they aren't, but then it's also still long-lasting trauma with no reprimand for that clinician. And I think that's the biggest thing that I have not seen is a reprimand for that clinician. Perfect example, and I will leave it here. It was a new nurse and an OB. Well, first when I first started, this is how I got introduced into birth work, because I thought it was daffodils and lilies. And then I had a mama who was on her 9th child. She was on Medicaid, and she wanted to keep her placenta. And I guess this nurse didn't understand what that meant because she had looked at the form, the consent to treat, and she just wanted her to cross out the line where it said keep bodily organs and things initially so that she could sign the document. Well, it was translated to the charge nurse that she wasn't compliant. She didn't want to sign it. The charge nurse came into the room, ripped the Pitocin plug out the wall, and said, well, since you don't want to sign this, we can't treat you. I kid y'all not, this is my 3rd birth. I was like, what is happening? And at that time, I didn't even understand, how to make a complaint, anything like that. So it gets worse. Then mom's blood pressure goes sky high. I'm stroke level. She would not take the medicine. And I'm like, okay, mom, I'm trying to tell her, well, look, you need this medicine. She was like, no, these people trying to kill me, da, 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 da. And her and baby are heart rate high, everything. So I was like, well, ma'am, you all can't come back in here and we need another clinician. They had to call a Black doctor that was not on call all the way up to the hospital. It took her 40 minutes to get there. And mom is still in high stroke levels and everything. And the only reason why she took it was because that Black doctor came in there. That's the only reason. And mom had just suffered the loss of the child's father, who the baby that was in her stomach. I kid y'all not, it was the craziest. And that's why I go so hard as being a doula. So now from that
to now, it's a little different. I think I remember having a client where the client wanted to do the delayed cord clamping. Doctor didn't believe in it. And I had a nurse that said, oh no, doc, I think she said she wanted to do delayed cord clamping. And put her hand on the doctor's shoulder, like, no, we got none of that. You know, so it's those type of things. I'll be like, oh my goodness, this is amazing. When I was a doula to different clinicians, you've seen the dynamic. They get, beautiful births. You know what I mean? Like everything is in place. Everybody's so helpful. But then when you have this mom on Medicaid who don't know anybody in the clinical system except me, then she's looked at differently. So I think it is transitioning. The forecast is shifting. But I think the reprimand for when you come across clinicians who don't understand this collaborative effort needs to be something.
So do they, do they like put a post in the hospitals? Cause I had like 4 kids and back. Nowhere, and I'm a provider.
Yeah.
Nowhere did they say, we have a doula, or you got a doula for.
You got to get that in the prenatal. That shouldn't meet you in the hospital.
That's it, every pregnancy.
But it's not advertised. It's not advertised at all.
Yeah, how does that know?
That's where it needs to be, in the offices and the
education
peds, in
of
education.
the conversation, the education, the spaces that we're in now. And I know that we shout out to, community health workers, but this is where somebody said the people that don't know, right? And I'm just gonna put, we right here are live right now on social media. One of my visions was, how do we take these conversations and put them on places where we know the people are, right?
Yeah.
People are on YouTube, people are on Facebook, people are on Instagram. So when we uplift these conversations that we're having here, people can see them and hear them, even if they're not in the space, because they need to. So I just say, shout out to those who are watching us, who will come back and watch this again. Thank you for tuning into the Hood Talks podcast. Make sure you share this live, and all of y'all go share this information too, so that people can have it, okay?
We have Dr. Zanelle Cabelli, chair of DYN over at WashU and BJC. She came